So Sam's asked me to talk a little bit about medication adherence, which, while it's fantastic that our colleagues in industry are making new drugs, it's more important that we actually have patients absorb those medications and take them on a regular basis. Like all of my programs, or I get a chance to talk about something that has nothing to do with the topic and tell a story. So today's story is about my son, Christopher Fanikos, who, when he graduated out of high school, decided to come join us here at Brigham and Women's Hospital and work during the summer months. And you see his picture there, and he joined our anticoagulation clinic. So if you're a patient, we put Christopher on the phones, and he made phone calls to laboratories and bird dogged them for results. He called patients to make sure that they had their lab testing done. And I think he did a good job. He was an extra set of hands, and it was fun to have him around. Of course, he left and moved on to bigger and better things and went on to college. And, you know, that's his roommates there. And he went on to the big city of New York and Lower Manhattan. You may recognize the Washington Square Park area because he resides now at New York University, which surrounds the park, and did his work, or does his work there. And in one of his early classes, one of his professors tried to instill some confidence, you know, in the group, and so their exercise was to stand in front of the class and tell everyone who you were and what you had accomplished in your life, what you were an expert in, and what you had done to reflect that. And so, as you might expect, in a group of 18-year, 20-year-old kids, young adults, they moved around the room, and, you know, each kid stumbled and tried to find something that they could talk about until, of course, they got to my son, who immediately announced, you know, "Hi, my name is Chris Fanikos, and I'm an expert in anticoagulation management because I've worked at the Coumadin Clinic at Brigham and Women's Hospital with Dr. Samuel Z. Goldhaber, and we've published numerous articles in New England Journal of Medicine." So the surprising thing is after he announced this with great conviction, there was dead silence in the room. And then someone in the back said, "Whoa, Sam Goldhaber." Awesome. And I see apparently someone's mother or father had been a patient of Dr. Goldhaber's, and he recognized the name. Now, I can assure you, I've never published anything in New England Journal of Medicine, and I know my son hasn't either, but, you know, amongst his friends and colleagues, I would tell you, in college, you know, when I was in college, they always emphasized at the top, substance over form, and in this instance, clearly it was form over substance. But he got his message across, and I think the important message I want to give to you today in the world of medicine is I think it's been a lot of form over substance as it relates to the medications themselves. Not so much in the studies that have been done and accomplished by industry and by researchers like Dr. Goldhaber and Dr. Piazza, Dr. Sasahara. Those are meticulously performed. But then the end results, as we move forward, I think, need to be improved. So here's my outline. I'll talk a little bit about medication use here in the United States. I'll talk about our problem with medication adherence, some of the barriers. I'll give you some suggestions or possible solutions. And again, focus on substance over form. We'll talk about next steps and potential conclusions. Here's the scope of medication use in the United States, and to me it's staggering. These are the numbers that were provided by the Center for Disease Control, and I'd urge you to focus on the very right-hand side of the slide, that if we look across the population of the United States, about half of Americans are taking at least one medication. About 1 out of 3 citizens in the United States are on 2 or more medications. And what is incredible to me is that about 10% of U.S. citizens are on 5 or more medications. So we are a heavily medicated society, which I find to be amazing. And it shouldn't be surprising that the focus of who uses these medications is on the elderly or those patients over the age of 60. And you can see that there is a huge jump in medication use in patients once they reach the age of 60 and become older. So you can look at the numbers, but about 40% of patients over the age of 60 are taking 5 or more medications. To me, that is really an incredible number of where we spend our resources. And for the sake of today's meeting, I think it's important to recognize that about 1 out of every 10 patients or every citizen in the United States is on an anticoagulant. 1 out of every 10 is on an antiplatelet medication. So we use our anticoagulants and antiplatelet medications routinely in patients that need them. So a lot of drug use in the United States. That's really not the problem. The problem resides in sticking to medication regimens. And specifically, we're talking about medication adherence. And there are multiple facets of medication adherence that you need to consider. And some of them arise at the moment patients have prescriptions put into their hands. You can see that some patients fail to fill their prescriptions. They don't refill their prescriptions. They omit doses. Sometimes when they don't think the drug's working, they take more than they should. Many people prematurely stop their medications on their own. Patients take doses at the wrong time. I know this from my in-laws that are retired down in Florida, that elderly patients often share medications, which is surprising to me. And then just simply the instructions that you should follow with regards to things like meals and food. People don't typically follow the instructions that we've outlined as healthcare professionals. So there's a lot of misuse of medications and then simply patients not following the way they should. What does this result in across the U.S.? Well, about 125 deaths are estimated in the U.S. every year associated with incorrect medication use. And when you think about this and the drugs that we have available and what their intentions are, it doesn't come as a surprise to me. About 1/3 to 2/3 of medication-related events that bring patients to the hospital are related to poor medication adherence. So if we give them a prescription and they take it home, if they don't follow the instructions, that underlying disease is going to come back and bring them back to us. Long-term adherence rates only reach about 50% among patients. So if you're giving somebody a medication that they're going to be on for the rest of their life, the likelihood that they're going to stick with that regimen is pretty slim. And the cost estimated, again, to the U.S. is about $290 billion a year. So a lot of drugs being dispensed, a lot of drugs being sold, a lot of drugs misused, and really not getting the bang for the buck that's intended in the research trials, clinical trials that have been performed. My parents are in their 80s now, and I've become far more aware of the issues surrounding the elderly patients. And I know from dealing with my dad, sometimes the elderly are not the easiest people in the world. And I don't disagree with my dad on anything, but I do know that, 1/3 of elderly patients never comply with what their regimen was prescribed. They discontinue prematurely. They make errors. That shouldn't come as a surprise either. About 1 in 5 fail to fill their prescriptions. And the real number is my parents are like many of the elderly outside. They live on their own. They take care of themselves. And so there aren't healthcare providers, at their beck and call if they need assistance. They're really responsible for their own care. I've mentioned some of the consequences. They show up to us or return to us in our emergency room. They show up with urgent visits to physicians' offices. These required, additional diagnostic tests. And the reason for that is we don't know if the medications that have been prescribed have failed or if it's a result of the disease progressing. And so we essentially do our workups all over again. And you can see the potential outcomes, with things like anticoagulants, cardiac medications, having 2 teenage daughters. The birth control thing is always in the background for anybody that has daughters. And, these are things you worry about making the drugs work while they're intended. I put this additional slide in. I don't think it's in your handout because I had thought about this, and there are medication adherence scales now that are being developed. This one is the one that's most recently cited in the research. And the idea is that you take a patient and you ask him a series of questions, and based on his responses, you attach some point scores. And in the end, the hope is that, you know, you can identify patients that are likely to follow medication regimens, or more importantly, identifying those that aren't going to follow their regimens. What I'll tell you is this is a starting tool. It's been adjudicated, validated in a couple of trials, but it still doesn't tell us what to do next when we identify those patients. I showed this slide last year, and it's intriguing to me because the folks that actually generate your credit score so you can get a mortgage or go buy a car or have access to credit cards have developed a medication adherence score. And you should recognize that because of the investment in health insurance and medication and health care, that these folks have a vested interest in knowing which patients are going to take their drugs and be free of disease, especially from an economic standpoint. And so while they won't tell you exactly how they've created their medication adherence score, it is on a point scale, and all of the information that they capture is based on information that's readily available in the public. Things like your credit history, what you owe for loans, the types of credit that you have, in addition to your age, sex, gender, family size, and assets. So to me, if you think about this, this is an interesting strategy. I'll come back to it, about incorporating the elements of money to get people to do what you want them to do. There have been a number of programs that have been rolled out to try to improve adherence, but again, I focus on the concepts of substance over form. This one was in New York City. It was directed at clinicians, and it was done, it was funded. It had funding for the program. It was done over 2 years, but all they did was reach 98 clinicians in the New York City area. And to me, with all the major hospitals that are in the city, to be able to just reach out and touch only 100 practitioners is a pretty, pretty dismal performance, I think, and a long way to go. So the tools are still there. The program is no longer funded, but it kind of gives you a flavor of the efforts that have been put forth. So what are the causes of why people don't take their medications? Well, like I said, it's multifaceted and it's different for lots of patients. I put together this little slide that, there are clearly different motivating factors for patients, including understanding why they're taking their medications. You'll find from many of the studies that the patients actually have to perceive that they're getting some benefit. And you should recognize that drugs like anticoagulants, there is no perceivable benefit. The patients don't know that they're working. There isn't anything they can point to. If you have pneumonia and we give you an antibiotic, I can assure you, and within a couple of days you'll feel better. But if we do give you a dose of anticoagulant, there is nothing discernible typically for the patient to recognize, especially over the long haul. There's fear, especially with understanding. There are a whole bunch of economic issues that I'll talk about in a minute, and I think that becomes a major issue for the American public. And there are communication issues. And many of them are incumbent on us in the way we do business here at the hospital. And we have made it very easy for patients to get in here with things like valet service. We've made it very easy to get appointments scheduled and push individuals through the organization. But the time that they actually spend with the patients, our clinicians spend with the patients, is somewhat limited. What I've set aside is these factors don't even deal with issues about the medications themselves. We'll talk about that. And the disease states. Patients don't feel good. And in some instances, we can't improve their underlying condition more than their baseline situation. So in the seminal article that has been published in New England Journal of Medicine, they point out another whole bunch of factors that contribute to patients' adherence, the complexity of the regimens that we give. And I think if you're taking more than one medication, everything becomes complex. Building your medication, taking into your lifestyle, cost and relationships, side effects, etc. And then just simple things like forgetting and other priorities. So all of this translates into no two patients or one patient being the same. Everybody is different and has different things to consider. I'll briefly talk about side effects because that's not my topic today, but to only simply tell you that when you take something like the antiplatelet drug clopidogrel, which is intended to prevent clots, that the major complication is nuisance bleeding, things like nosebleeds and skin bleeds when you're shaving, etc., and major bleeding events. All of these things contribute to getting patients to derail or disconnect and stop taking their medications. So simple events. I can assure you I only need a small excuse not to exercise every day, and the same thing is true with things like medication. When we get into the economics, the problems become magnified. This was work that was done by a group here at Brigham and Women's Hospital through CVS pharmacies. And what I can tell you is if you look at this graph, the story is right here. As the cost of medications become larger, the likelihood that they'll either abandon a medication or simply delay the time period that it's filled becomes magnified. So the cost itself of medications is a barrier. Is delaying your prescription a problem? It sure is, and I'll come back to the same antiplatelet drug, that in 7,000 patients that they looked at, you can see that there was a twofold increase in patients with death or recurrent myocardial infarction that were late or never had their prescription filled. So not getting your prescription filled right off the top is a major obstacle to many patients. I put this in because we've had two great drug discoveries in the realm of anticoagulation and the drugs dabigatran and rivaroxaban. And our insurance companies typically put these in a tiered status that makes them very, very expensive for patients to afford, specifically out of pocket. And for those of you that have Medicare Part D and rely on coverage, once you get into this donut hole, so the way that it's set up is, the enrollee pays typically 25% of the cost up until some point where there's no coverage. And that's the bad spot to be in. After that point, the government helps and kicks in. But this big donut hole is the area that we worry about, especially with the elderly. Is that a problem? It sure is. And there's been a number of studies that show, especially with cardiovascular medications, that once patients reach that donut hole, there's about 21% decline in overall drug use with cardiovascular meds. So we're running into this more and more. And finally, again, a group here at Brigham and Women's Hospital looked at it. Once you reach that donut hole, there's about a 50% increase in likelihood of stopping your cardiovascular drug. These are the different drugs that you'd probably recognize if you had high blood pressure or cholesterolemia or require some sort of antiplatelet or anticoagulant drug. My point here is that there are, these barriers become very, very important for patients to overcome. Are there potential solutions? Well, aren't we doing stuff in the world of pharmacy and the world of medicine? This is my daughter, so this is clearly a HIPAA violation, but I had to get an inhaler filled for her. This is the actual size of the insert that CVS Pharmacy gave out. I'm not chastising them because I reprinted the ones from our pharmacy here at Brigham and Women's Hospital. The font is equally small in size, and I challenge you to read any of this medication. There's lots and lots of information here, but when we followed up with our patients coming through our own pharmacy, we found out most of the patients threw this stuff away. I'll point to the other the attempt on our end to make these things important is warning labels that we put on vials and the labels themselves. There was a recent study that looked at both young adults and those over the age of 50. They actually tracked patients to see what they were looking at. And I can tell you that the vast majority of patients fail to read any of the labels. So once they're told what it is, they just blindly open up the bottle and go through business. And so, what we've done in the past up to this point is simply not good enough with what we've had. There are a whole bunch of companies that are working on this. And I give them credit. This is a company out of Baltimore. We have used them routinely now with our HIV patients that have lots of cocktails of medications. And basically what they're trying to do is put the medications into containers so that your daily dose or your timing of your dose, all the medications are put together and that you can just simply tear off that pack and take your medications and hopefully will improve adherence. I've shown some other things that are out there that are tied to alerting functions. devices that you can carry and set up times to alerts. There is even a pill phone option within your iPhone or any other electronic cell phone device you can set up and alert you for your own medications. And there is an organization now that's online, myschedule.com, that you can set up and print out your own calendars. We do this for all our patients that leave the hospital. If they wish to have a calendar, we generate it. But you can do this at home. You can put it into a cell phone device, and you can log on to the internet and create your own schedules and print out schedules and draft reminders by text or email. And so this is a start. It's a good start. I think not enough patients know about these things, and we certainly haven't tested them. So again, I come to the concept of substance over form. I know Greg's going to talk about the Surgeon General, and I'll skip that. But I'll talk about this little device that is very similar, that has all your medications color-coded. They're tied into an electronic system that chimes when your medications do, alerts you via cell phone. And the good part here is if you look, each row here represents a patient. Each column represents a dosing event. The red is the missing events in a study that was done through our healthcare technology group at Partners. By using those devices that chime, you can see that the adherence was improved dramatically from red to green. So I think we're on the right track, but we have a ways to go. And then the last technology I just wanted to briefly tell you, because this just got approved a few weeks ago, was a company out in California that's embedded a chip onto the medications themselves. Your stomach acids actually generates an electronic signal, which is pretty cool, to a device that's worn on your body, and that'll keep track of all the medications that you've taken and then send that information on to your practitioner. I thought that was pretty cool. So yeah, someone's going to make, I think that it's a good idea, right? If you take the medication and you wear the patch, everything will work out pretty well for you. So it sends a signal, and I think that's a start. One of the last things I wanted to talk about was financial incentives, because I find that nothing becomes more magnified than touching people in their own pocket. And this was a study that actually paid people to come to clinic visits and paid people to take their medications. I was surprised that the expense or the contribution that was provided to the patients ranged from anywhere from $3.50 to $10. And it shouldn't come as a surprise, right? Some people are motivated by small amounts of money. And the studies, it was, and so this study looked across all studies that used some sort of form of reimbursement, whether it was to treat patients with tuberculosis, to prevent drug substance abuse, HIV treatment, hepatitis treatment, psychotic or mental illness, or stroke prevention. But the point is they provided a small amount of medication, a small amount of reimbursement. It ranged anywhere from $160 over the course of a study in a year's time to $1,100 to $1,200. And some of the reimbursements were vouchers, cash, food, etc. But the point I have is that you can move people to doing things you want by incentivizing them on the basis of money. And when you think about that, whether it's medication, exercise, diet, etc., this may be something moving to the future. The other thing I'll point to, and I brought this up because I thought it was a good idea, we have these voucher cards in our pharmacy. The beauty of the voucher cards is that you can provide these to patients, and it'll reduce their copay anywhere from $10 to like $30, with a maximum benefit of like $100 per month. So basically, if you have a copayment that's astronomical, you can take this card to your pharmacy and they'll provide you with some benefit. There was just a recent editorial in JAMA that suggested this isn't a great idea. It's great for patients because their out-of-pocket expense is good, but the author of the editorial suggested that in the end, while the patient walks away with no burden, the insurance companies do walk away with a burden, and maybe generic drugs would be cheaper, but in the end, the burden to the healthcare system is still there. I can't argue with that, but it's the perspective that you look at. The patients love these options. When we move forward, how do we figure this out economically? I think there's more to talk about. Again, There are other studies that looked at trying to combine all the pills into one. So rather than taking 5 or 6 pills at once, let's combine them all into one poly pill. And again, maybe not a bad idea, some improved performance there. And the last thing I'll talk about is, one of the things we don't do well is communicate to patients. I showed this study last year when I talked. This study looked at 7 medications that patients were taking 1, 2, or 3 times a day. If someone sat down with them and actually organized their regimens, they could reduce 4 administrations of drug over the course of a day. When it was left up to a patient's own devices, that they were taking medications as many as 14 times a day. So sometimes communicating at the time of medicating is incredibly important, and helping patients organize their life becomes very important. Greg's going to talk about the element of interacting with patients, and I can't discount the elements of what the overall system here has in terms of making our patients' lives easier. So my next steps is I think we need to have an action plan for every patient that has a medication regimen that's instilled. I think a lot of it is incumbent upon the pharmacist, and there's an important role here and for us in the hospital in transitioning patients, and then certainly making sure that they have no delays and have their prescriptions filled. But more importantly, in the community setting, when they're outside of our purview, that those pharmacists and the clinicians that are places like CVS, Walgreens, and community pharmacies need to communicate, start employing some of these tools and maybe the incentives to get patients to take the drugs that they want. So I'll finish here. My message to you is we have some new devices, new tools, new opportunities. We haven't studied these in any great sense. So to go back to my son, I think we need to research these more and find the ones that work and the types of patients where they'll be successful. So substance over form. The adherence issue is common and it costs a lot of money. It's complex and there's lots of causes. I don't think we have a single home run ball to fix everything, but I do think we can empower patients with these tools and techniques and certainly improve the way they take medications. And then finally, for us clinicians that are out there, we need to reinforce these behaviors to make sure the drugs that have been invented for us actually do the work that's intended. So thank you very much.
Well, we learned a lot from what you had to say, and I think it started off as a pretty depressing message about
my son.
About what we about what we prescribe and things going to happen, but it became gradually more hopeful toward the end. I think you sort of left us on an upbeat note. With all the problems you outlined with medication adherence and all the potential solutions, how would you prioritize both the problems and the solutions?
Yeah, I think that's a great question, Sam. To me, the overall, our biggest burden in healthcare is really the cardiovascular patients. And if you think about this, hypertension, hypercholesterolemia, hyperlipidemia, the underlying scourge of diabetes, all of these drugs require chronic use. And I think that's really the population that we really should be focusing on is establishing a foothold in that arena, because we've got lots of patients, common drug use, and an opportunity to employ a lot of these different strategies. So to me, that's where we go.
Questions or comments for John? Catherine?
So a lot of these older patients don't know how to use a computer. They don't have access to the internet, and it seems that nobody's telling them about these programs that are available to them. So is there anything being done to get the word out about these, like in pharmacies or in doctors' offices?
My answer, Catherine, is no. At one point here, we had a very robust indigent care program that was supported by the hospital, and we had folks dedicated towards ensuring that these coverage gaps were provided. We've moved away from that, and a lot of it has to do with the fact that there's universal coverage in Massachusetts, and we weren't allowed to access many of these programs. I think we're reevaluating that here at the hospital. I know we have, because we're working back on it now to see what we can reestablish. But I think you've hit the nail on the head. For the average patient without access, I think it's incumbent on the clinicians that are out there as part of their workup to make sure that patients have access to the medications and they can afford them. And if they don't, what are the next steps that we do in terms of alternatives, whether it's support from industry or whether we choose an alternative drug that may be less expensive that they can afford. So I think there's more to come.
And Catherine, you're certainly on the front lines because you handle many hundreds of patient calls working as my administrative coordinator. And so you see the spectrum of patients, and I think it's right. We don't know a lot. We don't know about a lot of these programs to tell our patients, and a lot of the high tech ones are very cool, but don't really apply in a realistic way to that segment of my practice that would call you just really lost about where to turn. Dr. Ledoux.
Excellent talk, Dr. Fanikos. I completely agree with all the points. One of the other things I bring up as a cardiologist, and I see patients on regularly 20 different medicines, is the issue that patients oftentimes don't know what they're taking. They don't even come to the office with their medications. And the easy question for a medical assistant is, are you taking the same medicines as last time? As we all know, patients get hospitalized, things get changed, they go see one doctor, things get changed, see another doctor. And I'm very, very meticulous about that. I tell the patients, you have to bring your medicines to each and every visit. If you come see me, if you go see your primary care doctor, please do that so that things can get reconciled, mainly to see if there are any potential drug interactions. There are so many medications that interact with each other. I would say at least once or twice a day I see patients on a statin and some other medicine that are directly contraindicated, and I catch that and I change it, and nobody else has seen that. So I think that if we as physicians tell our educate patients, please, it doesn't matter if you've seen the doctor 100 times, take your medicines, write it down. Savvy patients will write it on a computer form and print it out, keep it in their wallet, specifically if they go to the hospital, because if they don't know what's being given, the hospital doesn't know. There are all sorts of potentials for problems.
That's such an important point. We have electronic medical records at Brigham and Women's, but the records are only as good as they're accurate. And you mentioned, John, that we don't have that much FaceTime with our patients. Certainly, a lot of the FaceTime that we do have, at least in my practice, is spent correcting the erroneous list of medications that's in the patient record. Dr. Ledoux.
Thank you. I'm not practicing, but I do give counseling to many patients. What I've found is that I can divide the patients in two groups. Patients who have symptoms, they are more compliant. The patients who don't have symptoms, diabetes, thyroid, they appear to be a lot more less compliant. And this is a major challenge. Any thoughts on that?
Yeah,
sure. Summarize the question.
So the question, of course, is for patients that are asymptomatic, they're the ones that end up being the most likely not to adhere to their medications. And again, I come to the point that there's no discernible benefit to the medications that have been prescribed, and in many instances make them feel worse. If you look at antihypertensive medications. And my take is I think this is where we need to look at other alternatives in terms of stimulating compliance. I won't use the word force, but, can we use some sort of other tools? And the concept of financial incentives, the concept of a chime or an alert, the concept of building things into your daily schedule that are monitored or reported back, like a report card of some kind. And this is not, I think, the government weighing in as a surveillance method, but more importantly, to give people real-time feedback of what their own performance is and then what the potential downsides are. And I really think we're on the cusp of that. You know, with all the electronics we have in iPhones and cell phones and laptop computers, the internet, I got to believe that'll be the next step is getting that population of patients with those drugs into some sort of, you know, gauge. You know, you get in your car, you look to see if there's gas, you know whether you're safe. That type of approach is, I think, what we're looking for.
Great. Jonathan.
I know compliance is a big issue because I do work with pharmaceutical distributors. And if there were an error feedback loop so that the patient saw when he or she was not complying, they will typically self-comply and come into adherence. So when I think about the supply chain, you could have something like, and I'm not pretending to be an expert, you know, if you had a pill box with RFID, then that could create a loop, but then the pill could come out of the box but not into the patient. So you've got a missing gap. But something like that would probably be more effective. The issue really is, does the patient know in real time when he or she is not complying? Because if you put that into the system, usually people will self-correct. So you see that with people correcting accounts receivable invoices and all sorts of things.
Any comments?
I don't.
Okay. Yes, please. Mr. Bender.
Thank you. My field is disability. I've represented maybe 400,000 people in this country on cases involving disability, and I'd say 30% are SSI, so they're really very poor. I hear them testify all the time. When they get to a hearing, the judge will say, "Why do you take this drug?" And we make them bring their vials because none of them have any idea what they're taking. So we make them bring them so at least we know what they are, and they'll say they don't know. Or they'll say things like heart. No idea why they're taking it. And I think it's really gotten much worse because I'd also guess that right now 25% of my clients, particularly in the rural areas, never see a doctor. They see a nurse practitioner. And when I started doing that, I thought that would be great because doctors are too busy to explain to patients what the drugs are for. But gee, a nurse really does have the time, and it's more of the nurse's training for the nurse to be able to explain to the patient carefully, this is what this drug is for, and you take this when. But now the nurses really basically are substitutes for the doctors and have just the same amount of time. So I would say the problem, at least for my clients who are often poorly educated in rural parts of the country, are staggeringly worse than the situation you're having here in a great hospital. And it's pretty bad here. And I don't know, we have to write everything out over and over again and tell the people to bring it with them. Because otherwise they simply are too disorganized or not educated enough or don't understand it. And everything that I write in almost an embarrassingly dumbed-down way, aiming at a person with an 8th grade education. But I'm guessing that's 30% of this country. And those who are not English speaking as a first language, that really makes it worse. So I am frustrated by problems like this in my world, and it's relatively uncomplicated compared to your world. So I don't have it's not really a question. It's sort of I just want to let you know that, gee, if you think the problem is bad here, go to Western Kentucky.
Yeah.